Hi guys, today we'll be discussing question 20, edema from general pathology. So let's get right into it, starting off with the definition. And edema is defined as the accumulation of fluid in the extravascular or interstitial compartment. It is important that you mention the terms extravascular or interstitial in the exam so you can demonstrate your knowledge about this topic. And then moving on, we also need to be able to differentiate between an edema and an effusion. An effusion is also an accumulation of fluid, but it is different from an edema because it is not into the interstitial space, but rather into the preformed body cavities, which include the pleura, pericardium, and peritoneum. Apart from that, effusions are also termed in relation to the characteristics of the fluid, whether the fluid could be blood, serous, or watery contents. And they're basically, examples are hemothorax, hydrothorax, hydropericardium, hemopericardium, ascites. Ascites is an exception to the naming, uh, but that's also means hydroperitoneum. Uh, Apart from the hemothorax and hemopericardium, these are under effusions, but their main etiology comes from hemorrhage, so they also considered hemorrhages into the body cavities. Next, we can differentiate the different types of edematous fluids. So the characteristics of the fluids, can be either it could be an exudate or a transudate. An exudate is fluid which is rich in proteins and or cells, mainly white blood cells, because it is of an inflammatory process. It's a consequence of inflammation. Or you can have a transudate, which is more common, which is a fluid poor in proteins, no cells usually, and arises from non-inflammatory etiologies. Moving on, you have the pathogenesis. Now, you have to keep in mind there's a lot to be said about pathogenesis because there are multiple etiologies that can give rise to edema, which include increased hydrostatic pressure, decreased oncotic pressure, sodium and water retention, lymphatic drainage obstructions, and increased capillary permeability or changes in capillary permeability. We should be able to mention like a bit more detail about each of these points because this is crucial, the pathophysiological mechanisms, which could be asked in the patho exam as well. So before we do that, we just need to revise a bit of capillary dynamics from physiology and the forces that govern the fluid flow in capillaries between, the fluid exchange between the capillaries and the interstitium. So you have the main four starting forces, which are the capillary hydrostatic pressure and basically the blood pressure or the capillary pressure, which forces the fluid plasma out into the interstitium. And then you also have the interstitial hydrostatic pressure, which pushes against this capillary pressure, forcing, uh, trying to force the fluid into the capillary. And these are the two main hydrostatic pressures. Apart from that, we also have the plasma oncotic and the interstitial oncotic pressure. The plasma oncotic pressure is mainly by the protein albumin. So if you have problems with the liver, it's very important to keep this in mind. Problems with the liver, when you have decreased liver function, you would also have, in many cases, decreased albumin production. So when you have problems with the liver and albumin, you should always think one of the consequences or one of the signs that you would see in such patients would be edemas. And mainly, you would see edemas in, uh, or you could see, apart from edemas, you could also see ascites as one of the main signs in people with liver problems. Moving on, next, like the mechanisms by which each of these lead to edema. So when you have an increased hydrostatic pressure, it basically increases nerve filtration to the interstitium. It can be of various etiologies as venous congestion. So when you have venous congestion, what happens is that you have poor drainage of the venous system, so the blood starts pooling up. When the blood starts pooling up, an increased amount of blood would also increase the amount of blood pressure because it's directly related. So when you have more blood being pooled up, Increased pressure leads to increased net filtration. So that would give rise to edemas. You also have heart failure. So heart failure is very important because depending on whether it's right-sided or left-sided, uh, right, heart failure also was always accompanied by congestion in the previous circulation. So if you have left-sided heart failure, so the circulation before the left side, which is the pulmonary circulation, would be congested, and in right-sided heart failure, you would see the systemic venous circulation being congested, giving rise to edemas. So characteristic findings of right-sided heart failure include bilateral lower extremity edema of pitting type. We'll get into that later, pitting and non-pitting edema. And for left-sided heart failure, that will lead to venous congestion, and that gives rise to pulmonary edema. Then you also have constricted pericarditis, venous obstructions like thrombosis, pressure by tumors, etc. Basically, same principle. You prevent blood flow, blood accumulates, and increased pressure. Increased pressure leads to increased filtration. As simple as that. Moving on, we also have decreased plasma oncologic pressure. This also increases the net filtration into the interstitium because there is a lack of proteins which pull back the water, excess water from the interstitium to the plasma. So if you have a loss of this pulling force from the capillaries, it will also technically lead to increased filtration. And you can see this in conditions such as nephrotic syndrome, where you can have excessive loss of albumin, severely affecting the oncologic pressure. You can see it in liver cirrhosis when you have damage to the liver. A cirrhotic liver is incapable of maintaining adequate albumin production. So decreased albumin obviously decreases the oncologic pressure. And then in malnutrition, you have the unavailability of proteins, basically amino acids, which is not enough to sustain adequate production of these plasma proteins. Moving on to lymphatic drainage obstruction. So interstitial fluid is recycled and resorbed into the lymphatic circulation, which eventually will drain back into the venous system. So if you have an obstruction into the lymphatics, basically there would be an absence or decreased rate of drainage from the interstitium back into the venous system. And this affects that because if you have slower drainage, you can have with normal filtration, you will have a buildup of fluid in the interstitium, which would lead to edema. And pitting and non-pitting edemas basically are physical findings which you have in on patients, and that's due to lymphatic obstruction. So a pitting edema is basically if you imagine pressing onto an edematous region on the body, usually subcutaneously. For example, let's say on the legs, it leaves a pit after applying pressure. It's because when you apply the pressure, it forces that excessive fluid in the interstitium into the lymphatic circulation, creating a pit. And slowly that pit is removed as fluid surrounding comes in and takes up space where you just made the pressure. That's why it is termed pitting edema. And in non-pitting edema, basically when you have obstruction to the lymphatic drainage, even applying pressure would not force the excessive fluid into interstitium into the lymphatic circulation, hence a non-pitting edema. Changes in capillary permeability, this is mainly due to inflammatory processes and it results in localized edema. Triggers of inflammation may include infections, trauma, and other things. And this gives rise to exudative edema rich in proteins and cells and is usually self-limiting. Now, moving on, like we've discussed the definition, we've discussed the differences between an edema and effusion. We discussed the basics of the main pathophysiological mechanisms and pathogenesis of how edemas could occur. Now, the next main thing that we need to discuss is the morphology. And the morphology is quite important, both the macroscopic and microscopic. There's not a lot of microscopic characteristics that are important for general medicine, for this course of general pathology. But the gross overall macroscopy of the patient is quite important. And edema usually depends, like the appearance depends on where it is on the body. Mainly, it is seen in the subcutaneous regions. You see an enlarged area and it is usually gravity dependent. Hence, it tends to accumulate in the lower extremities or the lower parts of those regions where it occur. So some types of edema, which would be is periorbital edema. Basically, you see a swollen eye, uniform skin color, no signs of bleeding or necrosis, and it's seen mainly in renal disorders. So if you see a patient which has periorbital edema, unilateral or bilateral, one of the main differential diagnoses should be any kidney disorders. Apart from that, you have pulmonary edema, unilateral or bilaterally enlarged wet lungs, which can be up to 1.5 liters in weight. And there are multiple differential diagnoses for this, but some of them include, left side heart failure, and all the etiologies of left side heart failure should be there. Apart from that, you can also think of pulmonary disorders, in which you could have congestion. Apart from that, you can also have lower extremity. This is the more common types of edema you can see. It could be unilateral or bilateral. Unilaterally occurring edemas are usually of infectious etiologies, uh, but bilaterally occurring ones is more commonly seen in the right side heart failure. So one of the main features of right side heart failure is bilaterally enlarged legs, pitting edema. Another thing you can also have is brain edema, which have the morphology of the brain is narrow sulci with wide gyra. This is dangerous because it compresses the brain against the skull. Uh, and then, there can also be a risk of herniations, which could be very dangerous. Here are a few pictures. As you can see, this is the pitting edema in the lower extremity. It leaves a pit. We discussed the reason as to why there's a pit. And this is periorbital edema over here. You see it accumulates generally on the lower side of the orbit because of gravity depending. Complications of edema, depending on the extent of edema and location, generally you do not have many complications or no effects. As it compresses against the blood supply, it could impair perfusion. And when there is decreased perfusion, it also impairs wound healing because uh, the nutrients are necessary for healing. Pulmonary edema can cause dyspnea and respiratory failure and eventually death. Respiratory failure, there are two types. So basically, pulmonary edema can cause type 2 respiratory failure, but that's pathophysiology. Brain edema, again, we discussed this herniation and may cause arterial obstruction, and then the arterial obstructions can cause ischemic stroke and eventually death. So the key points you need to remember in the exam is the definition, the difference between an edema and an effusion, the main pathogenesis, and the morphology. Complications are good to know and important for some professors, such as Dr. Shiteski. He's very keen to know the main complications of different pathologies. And always remember that if you have edema, the three main organs you should be thinking about immediately are the liver, the heart, and the kidneys. Thank you.